All right, welcome everyone. My name is Ruhi and I'm a program manager with, can everyone hear me? Great.
Yes, you're good.
A program manager with the Sepsis Project. It's my pleasure today to introduce our speakers. So we'll go ahead and get started. Our first speaker today will be Dr. Elliot Main. Dr. Elliot Main founded and directed the California Maternal Quality Care Collaborative, or CMQCC, for the last 16 years and served as the chair of the California Maternal Mortality Review Committee during those years. Nationally, Dr. Main is a director for quality improvement implementation for Alliance for Innovation on Maternal Health, or AIM, the national project funded through HRSA and based at ACOG for supporting state perinatal quality collaboratives in their efforts to reduce maternal mortality and severe morbidity. Dr. Main is clinical professor of obstetrics and gynecology here at Stanford University and a member of the Dunleavy Maternal Fetal Medicine Center. With Dr. Bauer, Dr. Main co-edited the CMQCC Maternal Sepsis Toolkit and the AIM National Safety Bundle for Sepsis in Obstetric Care. Welcome, Dr. Main. Next, I'd like to welcome and introduce Dr. Kendra Smith. Kendra Smith is a consultant specializing in maternal health, health equity, and community health with over 15 years of experience. Kendra has served as equity advisor to CMQCC since 2021. She collaborates with CMQCC staff and partners on birth equity projects, including the Hospital Action Guide, Sepsis Project, CDC and TSV Project, and Birth Equity Collaborative, and internally to create a culture of equity. Kendra leads Smith Research and Consulting LLC, where she works with clients on various research, evaluation, and quality improvement and strategic initiatives. Welcome, Kendra. Next, we'd hear from Dr. Bauer. Dr. Melissa Bauer is dual fellowship trained in critical care and obstetric anesthesiology and an associate professor of anesthesiology at Duke University Medical Center. Dr. Bauer is independently funded by the National Institutes of Health, Eunice Kennedy Shriver National Institute of Child Health and Development, to work to reduce maternal mortality and morbidity from maternal sepsis. Her research is centered on the early identification and treatment of maternal sepsis and using patient and community engagement to improve maternal care. She currently serves as chair for the National Alliance for Innovation on Maternal Health Sepsis and Obstetrical Care Patient Safety Bundle Work Group with the American College of Obstetricians and Gynecologists and Alliance for Innovation on Maternal Health. Welcome, Dr. Bauer. And last but certainly not least, we will hear from Krista Zakowski. Krista Zakowski has worked in a variety of roles, including perinatal nurse, nursing faculty, certified nurse midwife, and nurse education specialist. This has provided her with experience in numerous settings, from very low-risk women delivering at home to high-risk patients in tertiary care centers. She completed her BSN at the College of New Jersey in Ewing and her MSN at the University of Pennsylvania in Philadelphia. Krista has experience implementing CMQCC toolkits within a healthcare system and has been involved with CMQCC's collaborative since 2011. In her role as clinical lead, she works directly with hospital teams, mentor nurses, mentor physicians, research partners, and the entire CMQCC staff to assess and improve care delivery in the state of California. She has served as a task force co-lead and co-author of CMQCC toolkits. Krista also engages with the rest of the country by working with state perinatal quality collaboratives nationally and as the California nurse representative for the Alliance for Innovation on Maternal Health. Welcome all of our speakers, and it's a pleasure to have you all here. With that, we'll turn it over to Dr. Main.
Next slide. Thank you, Ruhi, for the introductions. I just wanted to go back to the slide. I just wanted to say at the outset that the first 60 minutes is going to be about how background for our collaborative. And then the next 30 minutes will be really focused on the collaborative members themselves. So if you're from other states or in other settings, the first 60 minutes really is for you, and then we're going to concentrate on the nuts and bolts of the collaborative to follow. We are going to take questions at the end of the first hour at about the 50-minute mark for all the issues and speakers up to that point. So let me start us off with a little bit of background. Next slide. How we put it all together. We started it off, as most of the audience knows, with a toolkit on the diagnosis and treatment of sepsis some 3 years ago. We've been at this about 5 years of work coming to the point of launching a collaborative. That was then moved into a national safety bundle from ACOG and AIM. That Melissa and Ron Gibbs led. I was on the team that developed that. And then we were fortunate enough 2 years ago to get a planning grant to design a sepsis learning collaborative from both a patient and clinician standpoint. That process has been led by Melissa, myself, and Kendra Smith. So now here today, we're here to really talk about how to put this together in a learning collaborative in 2 states of Michigan and California. Next slide. So the background is that sepsis remains a major issue for us in maternity care. It's the second leading cause of maternal mortality after cardiovascular disease, since we've done a better job with hypertension and hemorrhage. It is the 3rd leading cause of severe maternal morbidity at delivery and is the 1st leading cause of major complications or morbidities in the antepartum and postpartum periods. It also has significant racial inequities for both Black and American Indian birthing persons, and it's also higher in Asian and Pacific Islanders. Next slide. So we're going to look at this today from 2 different perspectives. First, the clinical one. Why are we doing poorly with maternal sepsis? After all, we know how to treat sepsis. And there's 5 clinical points to consider. One is that it is relatively rare, but deadly when it happens. The definition of maternal sepsis is not standardized. We're going to go into that. The diagnostic approach is not well established in terms of what you need to draw or what criteria you use to make the diagnosis of sepsis. And all these factors lead to treatment that is often delayed and piecemeal. And then we have the special challenge of chorioamnionitis, which is in itself a poorly defined condition of fever and labor. And that has made it very hard to diagnose and distinguish from maternal sepsis. Next slide. There are many different infections that can lead to sepsis, and that can confound the picture. Pyelonephritis, chorioamnionitis, and pneumonia are the leading overall causes in 3 time periods. Next slide. So the diagnostic criteria for sepsis in the United States really pivots around two disparate ideas, 2 disparate approaches. One is the Sepsis 2 consensus document established in 2001, which is infection plus 2 or more systemic inflammatory response syndrome criteria. We're going to go into SIRS a little bit later, but that had been the standard and then revised in 2001 for a good long time. In 2016, the international and national group of sepsis experts convened and redefined sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection. So it was taking infection and then taking it one step further, saying that you had to have an organ dysfunction to get to be diagnosed as sepsis. However, in the United States, CMS still defines sepsis as infection plus SIRS, and severe infection is sepsis with end organ injury. This is the SEP1 measure, quality improvement measure that is required of every hospital in the United States. So this makes it a more challenging deal. Next slide. WHO has taken a different approach, or an approach consistent with the sepsis 3 international and national consensus, which is that for maternal sepsis, it is a life-threatening condition defined as organ dysfunction from any point in pregnancy. This has been endorsed by FIGO and is generally followed worldwide. And the WHO emphasizes the criteria of systemic inflammatory response syndrome, or SIRS, is not appropriate for diagnosing maternal sepsis. So I'm going to show you some data that would support that from our work so far over the last 2 years. Next slide. So we've been funded to do a series of studies to help provide direction here. This is the NIH money that I spoke about at the beginning. And the type of questions we're addressing is comes under the rubric of how well do sepsis screening tools work in pregnancy? What's their sensitivity and false positive rate? Are they affected by the physiological changes of pregnancy? Do the screening tests perform? How well do the screening tests perform if we're defining sepsis as end organ injury as opposed to just a diagnosis of sepsis? And then no one has really looked at the early pregnancy and postpartum patients to see if the criteria work well there. And then we are separately going to analyze chorioamnionitis, since that is our biggest challenge. Not shown today, but we're also doing work on redefining the criteria for end organ injury during pregnancy, because we know that pregnancy changes creatinine levels, platelet levels, and other criteria that are used for end organ injury. So let's go to the next slide, and we'll describe a study that has just been completed and is now in press in the Green Journal. We were able, with the help of multiple investigators from all over the country, including Sutter Health here in California. So we got electronic health record data from 59 hospitals in 12 states. Most of these, the vast majority of these, were community level hospitals. There were 11 major university hospitals, including Northwestern, Brigham and Women's, Baylor, UCSF, Duke, and others. But the majority were from community hospitals, including some small level 1s, some level 2s, and level 3s. And they included ones from the Northeast, from the Midwest, some from the South, and the far West. So these covered almost 600,000 births. We were able to obtain electronic health record data for their vital signs, for all their vital signs during admission, for all their laboratory values, and their diagnosis codes. And we identified almost 3,000 cases of maternal sepsis, far and away the largest sample size ever collected of maternal sepsis cases. From both delivery admissions, antepartum admissions, and postpartum admissions. We're going to present here in a moment the delivery admission data. And again, we divided them into with and without chorioamnionitis. For the cases of sepsis without chorioamnionitis, we matched them 4-to-1 with control patients. For the chorioamnionitis patients, we compared patients with sepsis and those without within the chorioamnionitis population of almost 15,000 cases of chorioamnionitis. Next slide. The 5 screening tests that we evaluated are shown here. They include the SIRS criteria on the far left, which is what is used in adult internal medicine for non-pregnant persons, showing a heart rate of 90 or a respiratory rate over 20. And everyone caring for pregnant women will recognize that those are easily achieved in most pregnant women in labor. we looked in the middle here of two different versions of maternal early warning systems, including one widely used on the East Coast, which is early warning criteria, including any one of the list of 7 criteria above. And maternal early warning triggers, which was developed by Larry Shields in Dignity Health here in California, which is an interesting approach using a two-level criteria, 1 red flag for very abnormal vital signs like a pulse over 130, or 2 yellow flags illustrated below. And then on the right are 2 pregnancy-adjusted criteria developed here in our CMQCC toolkit, based largely on the mute criteria from Dignity and the UCOS from the UK, from the Confidential Inquiry System in UK, which is also adjusted for pregnancy, but with different thresholds. So the goal of these analyses was to identify the best balance between sensitivity and screen positive, which is essentially the false positive rate. You don't want, you want to get as many cases as you can without the burden and the cost of having a very high rate of false positives. Next slide. So here's the first analysis of cases excluding chorioamnionitis and endometritis at delivery. And we divided this into sepsis by diagnosis codes versus sepsis with end organ injury. You can see only about 1/3 of the sepsis by diagnosis codes had actual codes that would indicate end organ injury, which is not to say that the rest did not have end organ injury. It's just that they could not be identified with ICD-10 codes. So the top line, CMQCC does the best job with the highest C statistic, which is the area under the curve, with a sensitivity of over 90% and a false positive or screen positive rate of 6.9%. SIRS and mute SIRS and mute pick up 96%, but with much higher false positive rates. It's not very helpful if you pick up 21 or 38% of all the patients in the population to get to your 96%. UCOS comes in the second, again, a pregnancy adjusted criteria here at 9.6% on the second from the bottom line. They perform similarly when you look at sepsis with end organ injury. So this gives us a direction to go. Next slide gives a little different story, looking at chorioamnionitis. We combine chorio and endometritis, seemingly that they're same, but this was actually about 94% chorioamnionitis cases here. None of these tests perform particularly well. SIRS and mute pick up essentially 90% of chorio patients, which has been shown in earlier studies that these tests are not very reliable. CMQCC has a screen positive rate of 60%, and it picks up most all the sepsis cases at 94%. 60% is a bit more than what one would like, for sure. Next slide. We started, this is going back to the CMQCC toolkit, with the concept that the initial screen was a screen for severe infection, and then you needed a second step. Next. And that really is the key step that we're discovering here in these analyses, that you need a formal bedside evaluation, and you need some formal direction for nurses or hospitalists or ER physicians who are doing this bedside evaluation. Next slide. The bedside evaluation is, we're doing an analysis and should be done in the next month or so to identify what would be the red flag levels of vital signs And there are some, particularly in pulse and respiratory rate and diastolic blood pressure, that I think are most promising. Temperature is a little tricky because most all these patients have a temperature. So this is underway. But the clinical evaluation that goes with re-looking at these vital signs is also very important. And these include the signs of sepsis. So a patient who is a screen positive for infection and has, for example, fever, shivering, or feeling very cold, or is disoriented, that's a person you need to evaluate promptly for end organ injury and or anybody who appears toxic or ill. We're also recommending that you have to evaluate for bleeding because obstetric hemorrhage has very similar vital sign abnormalities to sepsis. And we want to emphasize listening to the patient as we're going to discuss in detail in a moment. Next slide. This is reminiscent of what we do for neonatal term early onset sepsis. This is the sepsis calculator developed by Kaiser that's now widely used in a similar situation to which you have a large population of potentially infected persons, babies here, but with a rate that's only about 3 per 1,000, which is about the rate of maternal sepsis. And they combine laboratory values and clinical vital signs on the left-hand side here, and then do a calculation based on a clinical exam. The clinical exam then determines what you do. Next. What is next slide. What's proven to be most important of this whole process of the Kaiser's early onset screening is the standardized clinical evaluation and then the enhanced observation of people who were screen positive but not yet septic. And this is really going to be an important part of our approach going forward. Next slide. The evaluation for end organ injury is a series of laboratory tests. Lactate chemistry panel, redoing the CBC, looking for platelets abnormalities, and a coagulation panel. We will be looking, we are in the process of identifying the appropriate pregnancy cutoffs for these. That will be very helpful. In addition, there are 2 other end organ injury criteria that are not laboratory based, such as the need for respiratory support or blood pressure support, pressors, and CNS symptoms. Next slide. So what we've identified for key steps for the reduction of deaths and complications is that we need to standardize diagnostic criteria. And we think we're making headway there. We need to have people really thinking about sepsis, asking, listening carefully. And as Dr. Bauer will be describing in a few moments, treatment must be timely. Very good data saying that you have to get antibiotics and fluid support within an hour. And the special challenge of chorionitis and pneumonitis we're working on, and we think we're going to have some answers coming up shortly, but in any case, it is evaluate, reevaluate, and thinking sepsis. Next slide. We started off with the clinical signs, the clinical issues with why we are doing poorly with maternal sepsis, but there's a lot of patient-centered issues here. The patient and family members do not know the signs and symptoms of sepsis. Sepsis is not on patients' or doctors' minds. Symptoms are dismissed. Patients do not know how to best advocate for themselves. This has been the cornerstone of a lot of our work the last 2 years, led by Kendra Smith. I'm going to turn it over to her now. Thank you. Next slide.
Thank you, Elliot. Hi, everybody. I'm Kendra Smith, and I'm very happy to be here. I lead the community and patient engagement for this project. And in this section, I'll talk to you about the overall community engaged approach of this project and why it's been important to this phase. But first, next slide, please. I'd like to share a patient story. So Miley LaBeouf is a sepsis survivor, a patient advocate, and a member of our maternal sepsis community leadership board for this project. Miley had a horrific experience with maternal sepsis following the birth of her second child, and the video that you're about to watch details her clinical and personal experience with sepsis. Please take a look.
The one thing I 100% knew for sure always was that I wanted to be a mother. I gave birth to Gigi, and we definitely wanted a second child. 4 years later, we decided we were ready. It was 30 hours of labor. We were just having a really hard time. Kalia was just not budging. And finally, they gave me something to induce labor. The most amazing part was them putting her on my chest right away. That was totally incredible. I spent one night at the hospital. We went home the next day. I got home on a Friday and I started feeling really run down. Over the course of the weekend, I just kept feeling worse and worse. I started to feel like I had the flu, incredibly exhausted, trouble breathing. I didn't have a fever, but I had terrible, terrible chills. We did decide to call the OBGYN's office. I was told, very likely you're just dehydrated and you're overexerting yourself. You need to rest more. You need to drink more fluids. So we followed that advice. And then we kept calling because every day it was getting worse and worse. Symptoms included extreme shortness of breath, extreme fatigue, chills. My arms started hurting tremendously and started swelling. My breast milk stopped in the middle of the night and I had started vomiting. So after 5 days, we finally were able to get an appointment. And they checked my vitals several times because at one point my blood pressure was reading 88/40. Unbelievably low. So my pulse was at 121. Really scary. Again, I was told dehydration, overexertion, and I was prescribed bed rest and some painkillers. I went in for my exam on a Wednesday. Friday morning, I was blacking out and said, I feel like I'm dying. You feel so horrible. I mean, the worst you've ever felt in your entire life. At that point, we decided we need to call 911.
If she had delayed going to the hospital by an hour, she would have died. If she had gone to a local hospital that wasn't equipped, she would have died.
I was in the emergency room for several hours while they tried to get my blood pressure up.
At one point, she just stopped breathing. They used the paddles to resuscitate her, to get her heartbeat going again.
And then that day, they took me up to the ICU. I barely remember. And then that's it. I don't remember anything. I was in a coma for almost 2 weeks. The first time I heard the word sepsis ever in my life was when I came out of a coma. I was told that I had just survived sepsis and that I had gone into septic shock as a result of what they believed was a strep A infection that I contracted somehow during childbirth. I was at one point on 4 vasopressors, and the vasopressors were used to keep my lungs, heart, and brain functioning, which is why my limbs were black. My feet were black. Everything was bandaged, and I had wounds all over my arms and legs. I was extremely close to losing my right leg. It is really a miracle that I didn't die. I got really, really, really lucky. I'd only been out of the coma for a few days, and they brought Kalia to see me. I could barely hold her. I could barely hold the bottle to feed her because I was so weak. It was just so hard to not be able to provide for her and be her mom. It was really hard to be away. I stayed in the ICU for several more weeks. It was all about my wounds, how they're recovering. Am I going to lose my foot? Am I going to lose a toe? The next challenge was learning to walk again. I just kept very focused on the vision of being home. And when that day finally came, yay, I'm home. Happiest I've ever been in my life, for sure. When little Kalia was there, Gigi ran in with flowers and was so excited to have me home. And I was just so happy to be on my couch. In July, we decided that I should have a hysterectomy. My uterus was full of necrotic tissue. I had to go back a week later for several surgeries, 4 skin grafts. Once I was a year out, my right hip started really, really hurting me. Found out that I had a vascular necrosis in both of my hip joints, most likely as a result of all the vasopressors. A vascular necrosis is when the bone dies. So I had both of my hips replaced at age 40. Also found out that I have a vascular necrosis of my right talus bone. I'm young. I have 2 young daughters. That actually caused me a pretty severe depression because it meant that this was forever, that this was never going to go away. I think it's really important for everyone to understand that childbirth is a huge medical procedure. I think there's so much attention put on the newborn, and what a mother goes through, what her body goes through gets very dismissed. If I had known about sepsis before any of this happened, I would have been able to better advocate for myself, really push much harder to say, please take a blood test. I'm concerned that I have sepsis. So it's really important to be a part of that process, not just an innocent bystander, not just someone on the sidelines. You really have to be the leader.
Thank you. This video always touches me. We're grateful to Miley for sharing her story with us through this video, as well as in phase 1, as well as phase 2 of this project. Additionally, we also want to thank and acknowledge the Sepsis Alliance for producing this video and making it available for us to share with you. Miley's experience is not unlike many of the sepsis survivors we encountered during this project. So it's really good to be able to share her story. So now I'd like to transition to share with you our approach for this project. So this is a community engaged project, meaning that we worked collaboratively with communities of interest to build, design, and implement this project. This approach is particularly important and meaningful because it really elevates and includes the involvement of community members, not simply as research subjects, but as critical partners who have really aided and assisted in making this research more relevant, culturally meaningful, patient-centered, and equitable. So the core community of interest that we worked with for this project was the Maternal Sepsis Community Leadership Board. And the purpose of this board was to engage in research activities designed to understand and reduce maternal morbidity and mortality from sepsis while leveraging community experiences and voices. And this group was made up of about 14 people with lived experience with maternal sepsis, patient advocates, birth equity advocates, and community members from tribal communities and rural areas to really help shape what we were going to do in this project and how we were going to approach our work in this project. We wanted to understand disparities in maternal sepsis care. And in doing so, we could have come up with our overall approach and design for this research project on our own, but it really wouldn't have been appropriate. We needed to hear from people with lived experience with sepsis, and we needed to hear from people who have experience in public health and in nursing and things of that nature. And so we put together a really solid group who helped build what this project has come to be, and a very successful project at that. Next slide, please. So the project structure was made up of 3 groups. We had a group of clinician scientists, we had our patients with lived experience, and we had community partners. The clinician scientists worked heavily with Drs. Bauer and Main on the diagnostics assessment that Dr. Main went over earlier in this presentation. The patients and the community partners worked heavily with me and Drs. Bauer and Main on the development and execution of the qualitative portion of our study. And so the planning phase of this project largely involved our Maternal Sepsis Community Leadership Board, who really played a critical role in shaping the interview guides, aiding in recruitment, sense making of the findings, co-authoring a paper about the process that we use, as well as disseminating the findings. Some of our community leadership board members went out and disseminated information with Dr. Bauer at a maternal health conference, and we've done incredible work together. Next slide. So in addition to our community leadership board, we also leveraged expertise and experience from across California and across Michigan. And so this collaborative is taking place, as you know, in 2 states. And we have been very, very fortunate to have critical expertise to help shape what we will do in this collaborative from both states. Next slide. Also, something worth mentioning is that a key element of any community engaged project is that we work to ensure that our community partners are equipped to engage in this process, and that we work actively to reduce power differentials that would limit or prohibit them from engaging as they needed to. The strength of this project lies in the input and the feedback that we received from our community partners, and not us just using them as a rubber stamp to just hear what we wanted to do and then agreed with it. And so we did a considerable amount of community building with our group to make sure that there was a shared understanding of the overall goal and intent of this project, and that the group itself had its own project goals, and that we were giving space for disagreement, and that we were working collaboratively on the work products that we produce, and as well as working collaboratively with our clinical partners. Next slide. We had a formal feedback integration process to make sure that the feedback provided by the community group as well as our clinical group were adequately considered, appropriately considered, as well as integrated into this project to make sure that we were representing all of our stakeholders and collaborators in this project. Next slide, please. Finally, towards the end of phase 1 of our project, we did these really incredible collaborative sessions between our community partner group and our Maternal Sepsis Leadership Board and our clinical group who worked on this project to go through the findings of the study, as well as talk through the next steps for this project, which were things around warning signs for maternal sepsis and adjusting confirming and or adjusting the warning signs associated with the urgent maternal warning signs, as well as advocacy language that people could use, that birthing people can use when they're in the hospital settings. As you heard, sepsis is not on a lot of people's mind, and a lot of times the patients in their experience were told, well, you just had a baby, or go home, or you might be dehydrated. And so we actively worked as a group to identify different ways and different opportunities to adjust that experience and to give people the language and the knowledge to adjust those experiences to have better outcomes. So I will stop right there and I will pass it along to Dr. Bauer.
Hi, everyone. I'm going to talk about those tools that we ended up making with our our community leadership board. Next slide. As you know, sepsis is preventable. Those deaths are preventable. When 3 states looked at their maternal mortality due to sepsis, they found at least 40% of the time those deaths were preventable. Next slide. And in the states of Michigan and in California, they reviewed their deaths very deeply to see what were the delays that led to deaths. And they found, go ahead and hit next slide, delays in recognition, next slide, delays in treatment, and delays in escalation of care. Those led to the deaths. And so we created all of these materials so that we could avoid these 3 deadly delays. Next slide. So starting with recognition, most of this talk will focus on that. Next slide. A couple of in-hospital recognition pearls that I want you to be aware of, and then we'll tackle the rest. Most patients don't have any risk factors, so please don't just reevaluate and screen patients that have risk factors. You will miss a lot of patients that way. And when we looked at the data a few years ago at the National Inpatient Sample, we found that many of them had no risk factors at all. So please make sure that this is universal screening and evaluation. Additionally, no fever does not equal no sepsis. Many patients do not have a fever. The data that we recently published showed that 20 to 25% of people will not have a fever. And when we looked at the data in the state of Michigan, 80% of people, when they arrived to the hospital, did not have a fever, and 25% of them never developed one throughout their hospital stay, in which they died of sepsis. And also, when you're hearing concerns from the nurses or patients, make sure that you're curious. You ask a lot of questions of the patient and whoever's bringing the concern. We found a lot of cases of maternal mortality as well as severe maternal morbidity, and that patients were just reassured that everything was normal and that that there was nothing to be concerned about. So make sure that you ask a lot of questions and try to get down to the bottom of what those complaints are. And then also what is not in the chart can be most important. So while it's great to set up an alarm system, make sure that you have an alarm system if you're not getting some values. So many times there'll be a missing respiratory rate, there'll be a missing temperature. I recently evaluated a patient that was hypotensive, and I didn't see a temperature in the chart for quite a while. So I asked the nurse about it, and she said, I've been trying for the past hour. I've gotten 3 different machines and I wasn't able to get a temperature. The reason for that was the patient was so hypothermic, they couldn't register one. So make sure that your alarm system and your alert also alerts when you're not getting vital signs that you would expect. So next slide. So outside of the hospital, when we looked at this data with the National Readmission Database, we found that in the delivery hospitalization as well as postpartum readmission, 50% of the cases actually showed up in the postpartum readmission. And when you combine those with antepartum sepsis cases, you'll find that most cases actually occur outside of the hospital. So by implementing this, we need to be working outside in our communities and with our patients to identify when they need to seek care, and also helping that patient be listened to and feel heard. And I want to make a really big point here that we are not putting the onus on the patient to advocate for themselves because we think that that's where it should be. We're just acknowledging that patients, there's a lot of bias with maternal mortality and morbidity, and we know that we need to give some tools here, and we need to work on improving our inequities. But I want to just make that clear that we're not saying that that is their responsibility, but we have to give these tools because we know that that's what's going on. So when we go through that, I want to make that clear. Next slide. We interviewed 20 people that were survivors of maternal sepsis or were the support person of someone who did not survive. We also interviewed support persons who were present at that time so that we can get more information. Next slide. This was our qualitative part that Kendra was talking about. Our goals were to identify barriers to care, listen to patient stories and lessons learned, and create solutions to address barriers with our community leadership board. Next slide. A couple of quotes from some of the themes is that patients did not remember education about warning signs. One said, if I had known that was a sign to look for, I would have known it when I saw it. Another said, I think if when they discharged me, if they had said, be on the lookout for these symptoms, if you have any of them, call and check in. If they would have taken 5 minutes to do that, I think it would have made a huge difference. Next slide. And so what we showed our participants were these urgent maternal warning signs. These were created by the Council for Patient Safety and Women's Healthcare. They are owned by ACOG, supported by AIM, as well as the CDC, Hear Her campaign. If you see here, these are not specific to sepsis. These are signs for severe maternal morbidity that were created by patients, family members, as well as experts in the field to identify patients that would need to be seen who might have signs of impending severe maternal morbidity. They are translated into 14 languages, and it's a way to standardize patient education. We know that discharge education is not standardized, as well as there is bias that has been shown in some studies. So we want to make sure patients have all of this information available. Next slide, please. We also learned in our interviews that patients really want this on their phone. And the reason for that is that the stack of papers that are given, people don't usually read them. They end up in the trash, and people need something on their phone. Most everyone has a phone. We created a badge buddy that was shared with National AIM. They are now supporting this. It's available on their website. If you look at that QR code, you can go through the instructions on how to add it with Android and iPhone to that patient's phone during your discharge, rather than just doing it verbally or handing it out on a piece of paper. So we strongly recommend that you give this right onto their phone so they can see what these warning signs are. Next slide. Additionally, one of our other themes were patients wanted a way to advocate. It would have been helpful to have this list to give me the language in reference to the urgent maternal warning signs. I had these symptoms and knew something was wrong. My husband and I thought we should be advocating for ourselves, but didn't know what we were supposed to be advocating for. Patients and their support person should be taught to watch for warning signs and know what they could potentially mean and what to say when entering an emergency room. Next slide. And so we knew that we needed to create this advocacy language and actions. And so we co-created this with the Maternal Sepsis Community Leadership Board. So take a look at the next slide. The QR code is here. These are all available on the My AIM website. As you know, we're doing a joint collaborative. The next slide, this will make this a little bit bigger. So you can look here at some examples of advocacy language. These are words to be using to describe how they're feeling, as well as to advocate for themselves, such as, I'm very concerned, I do not feel like I'm being heard. What are my next steps or alternative options? There's a number of options here. And then hit next slide for some advocacy action tips. One more. The advocacy action tips are to, if you're having a problem, to seek care. A lot of people didn't know if you're not getting the response you need, you can go to triage or the emergency room. You do not need permission from anyone to do so. Unfortunately, many people didn't realize that that was the case. And so they didn't seek care. And so we want to make sure that people know these things and that this is also available. And so with that QR code, it can go to all these materials and they can have these advocacy action tips, as well as language to have on their phone. So when they are seeking care, that they have this set of action tips, such as bringing someone with you to help advocate for you. And it was something that we created together. And I think that it'll be a great tool for people to have, given that we know that there are inequities and bias. And we want to make sure that people have some additional tools. Next slide. Patient concerns were dismissed as normal. I was basically telling all my symptoms, but I was basically getting like, oh, that's normal. That's normal. So I was very brushed off and I didn't know any better. Next slide. But if they had asked further, so many patients reported being tired. And unfortunately, they were reassured that it's very normal to be tired postpartum, and they didn't get further evaluation. But if they had asked how it was limiting their ability to care for themselves or their little one, they would find that patients would say, I had no strength. I couldn't even go to the kitchen to get a glass of water. I was so weak, I couldn't stand up. I was short of breath after brushing my teeth and had to lie down on the bed. These would be very concerning if we were able to get that information and that it was affecting their activities of daily living. And so what we created on the next slide, this was in combination, go ahead and hit the next slide too. This was in combination with the Clinical Advisory Board, as well as the Maternal Sepsis Community Leadership Board. These are follow-up questions to make sure that we're standardizing the questions that we're asking, as well as making sure that we're really getting a gauge of how much that is affecting the patient. Because we want to make sure that we're really taking a good history over the phone and deciding, and then making the next steps with the physician about the plans for evaluation of that patient. There are different ranges and experience of someone who's answering the phone on the nurse line. It could be someone who's very new. It could be someone with 20 years experience. And we want to make sure that patients get the evaluation that they need when they're calling in. Next slide, please. I'll go through the bottom. Action items and red flags are also really important. We found that many of the people that we interviewed felt that they had talked to their provider. At the time that they talked to them, they didn't need further evaluation, but they got worse and worse, and they felt that they had already been evaluated and checked that off. So we want to make sure that we give red flag warning symptoms to people to know when they should seek care, or if things are worsening. And so it's really helpful to have these action items as well. And then with red flags, this should help prompt an in-person evaluation, patients reaching out multiple times with concerns. We had many patients reach out on multiple occasions and never have an in-person evaluation. And so it's helpful to keep track of that and to open up the chart and see that they have called multiple times. Severe pain was also a very common symptom of the people that we interviewed, and it was getting worse. And so that's also something that we weren't really expecting, but I think that it's important that we are aware of. So we look through and evaluate patients having severe pain. But there's a lot here to look through. Go ahead and put on your phone with that QR code, and you can have access to all of these materials. Next slide. And then just a couple more things on treatment and then escalation of care. Those are the other delays. Next slide. Treatment, there has been some controversy lately in the literature about the importance of getting in antibiotics within 1 hour in the ER and critical care literature. But when we looked at this at 7 centers with a case control a couple of years ago, we found that in the group of patients who received antibiotics that were pregnant, within 1 hour, the mortality was 8%. And after 1 hour is 20% mortality. It does matter even in young, healthy patients. So make sure that you want to get those antibiotics in as quickly as possible. A couple strategies to do that. Next slide. Please take a look at the CMQCC toolkit. This was a very nicely done part of it that shows first, second, and third line antibiotics for different conditions, that it will be really helpful for you to create a protocol before you have a patient who gets sick, so that you can easily click through and know the dosage and which types of antibiotics, so that you can get these antibiotics in quickly. Next slide. Additionally, some systems-based solutions that we found when we were doing that case control was that having the antibiotics at the bedside is really helpful. So work with your pharmacy to get it at the bedside and delivered when they order it, but also have it in your Pyxis. You can get partial doses placed in there. And then while you're administering those, you could get the additional dose, such as Gent. You could get 300 milligrams in the Pyxis that you can mix up, as well as vancomycin could be 1 gram, and then they can prepare the other 0.5 or 1.5 grams, however size that patient is, so that you could at least get those started. Additionally, ask for more IV access if you're a nurse, and also if you're a physician, see if you can offer that. Ask your anesthesiologist. We're very good at placing IVs. When nurses are giving antibiotics, usually there's 2 or 3 of them, and they look through their book about the compatibility, and they can't give them together. And so while you might meet the metric of started within 1 hour, it's not always the best thing for the patient if it takes 6 hours to get all those antibiotics in. So if you provide more IV access, you can get those in sooner. Additionally, there are some hospitals I'm aware of that had a policy that you can't start an antibiotic and then send that person for transport to either imaging or to the ICU because no one's monitoring them for a risk of allergic reaction. I would say that I would try to work to remove that barrier because you're much more likely to cause harm to a patient by delaying antibiotics. Next slide. Moving on to escalation of care, that's the final deadly delay. One more slide. So if you look here, this is the sepsis and obstetric score. This was published a couple of years ago in the Green Journal. It was retrospectively created, prospectively validated to help indicate that anyone with a score of 6 or higher should be in the ICU or correlated with an ICU admission. I'm not able to remember this as much as I like it, but go to the next slide. This is the sepsis calculator. You can go ahead and pull out your phone, go to perinatology.com. You can also go to that QR code that I showed with the MyA materials. It will link to this. You can go ahead and put in what the patient has for all of these. It will give you a score, 6 or more. That patient really should be in an elevated unit in an ICU or similar level. And also, if you have concerns about that patient at all, or concerns about the acuity on your floor, feel confident that you should escalate that patient's level of care. A lot of deaths occurred because people didn't recognize the signs of critical illness. And so you want to make sure that you can do that and assess every patient that you believe has severe infection or sepsis, and make sure that you escalate care as appropriate. Next slide. And that's all I have for now. We look forward to your questions. And I'm going to turn this over to Elliot.
Dr. Bauer, it's 7 p.m. on the East Coast. Dr. Bauer actually has to do night shift work as head of OB anesthesia. So we're going to thank her for her contribution, and I'm happy to take the clinical questions, and Kendra can address the patient-centered questions. There were a couple in the Q&A session that I'll start with. First one is about what value does lactate level or lactate level trending add to the diagnosis and treatment of maternal sepsis? And that's been an area of great controversy because lactate does rise with labor. It can get quite high at the end of labor or in the second stage because it's basically a marker of anaerobic metabolism. And people work a lot during labor. So the normal level of 2, the normal range up to 2 is no longer a value. 4 may be an area of interest. We're actually evaluating that currently. The good news is that it actually goes away pretty quickly diminishes quickly after delivery, so that by some 3 to 5 hours after delivery, it may be back to the normal expected range. So a value of 2 or more may then become significant. But that does limit us for lactate at during the active phase of labor, but particularly in the second stage. Other parameters have been studied, like procalcitome. Other markers have been examined, and they're actually, there's published data, one by Dr. Bauer, suggesting that are not of value. And so we don't have a good biomarker for it. Another question is about transferring to the ICU. And that was just covered by the SOS, or sepsis and obstetric score, which is focused particularly on that question. So I would defer you to that. That does give a score that if that's abnormal, you should be in the ICU, and that seems to be validated in a follow-up study. Another question I'm seeing here is a second line to give more than one antibiotic is a good idea, but the pharmacy is worried about, how do you tell which antibiotic might cause a reaction should the patient have a reaction? I think you can start one antibiotic, and then as you're partway through that, you can start the second one. The whole idea here is not to have multi-hour delays. A 30-minute delay in the first two antibiotics are pretty, AMP and Gent if you don't have an allergy to penicillin, are pretty standard ones. So I'm not so worried. I'm less worried about allergic reaction than about delays in administration of antibiotics. So there's a question about white cell count of 15 or 17 or 18. We've looked at actually a bunch of different cutoffs, and that appears to be a reasonable one for the first pass. Again, this is a screen for serious infection, not for sepsis in the screening test. To get improved specificity, you have to go above 20. But then you lose out on sensitivity. So we're looking at other parameters to do that, because the more abnormal any of these vital signs are, the more specific they're going to be, but the less sensitive they are. So if you went up to 130 for the pulse rate, there's going to be a lot of sepsis patients there, and there are going to be very few normal patients there, and in many of the sepsis patients, but not enough to make it a sensitive enough test. So white count, the next question is about white count rise that's seen in post-surgical patients. White count is relatively nonspecific. We know that white count rises in pregnancy. We know that it can rise in labor, and that limits its effectiveness as a screening test. But if you get really abnormal values, as I said, 18, 20 or more, that can be a concern. Next question, why do we count lactate postpartum within 3 to 4 hours after delivery as an organ dysfunction? It looks like that's when, and we have the data now with all these vital signs and laboratory tests to try and answer this very specifically, but the data so far suggests that lactate should be returning relatively quickly after delivery, in that 3 to 5 hour type of window to go back to becoming a marker of organ dysfunction. So what number of weeks postpartum should we continue to use the OB-specific screening tool? This is actually one of the parameters we look for. I didn't present today, but it is in the article in Press in the Green Journal. It actually, the physiological changes of pregnancy that affect this go away pretty quickly. So that by the time you're being readmitted 3 to 5 days later, you should the adult measures are probably no worse than the pregnancy adjusted measures. So we did recommend that you use those. We have been in communication with CMS, and CMS has agreed, actually did agree, this is now in their measure specifications, to use pregnancy adjusted values for the definition of SIRS, which is increasing the pulse rate, increasing the respiratory rate, from 20 weeks to the first week or so after delivery. So that is now in the specifications for the SEP1 measure. In regards to chorioamnionitis, do we recommend blood cultures if a patient meets sepsis criteria with organ dysfunction? Here, I think there's a big distinction between chorio and sepsis from other infectious causes. Blood cultures are really, really important for pyelonephritis, for sepsis from GI disorders and pneumonia. They've been less impressively useful for chorioamnionitis, so I would not delay any treatment, either fluids or antibiotics, pending getting blood cultures done. They're a secondary thing for chorio. Next question is looking at shock index for detecting sepsis. We've done a first pass, given all the vital signs we have, and we're going back and looking at that again to be able to answer that directly. It doesn't seem to be specific enough for us. The next question is about because lactate can't be used as a criteria for sepsis during late labor or immediately after delivery. I'm going to paraphrase that. The screen is delayed, and this is what we're trying to avoid, which is to have some other criteria to draw the rest of the labs and to begin the treatment for not just depending on lactate, i.e. if the patient is disoriented, if she looks toxic, that's grounds right there to start treatment and to get all the rest of the laboratory values. So we're broadening the criteria for diagnosing end organ injury. The next question is about if 50% happen postpartum. It's actually half in antepartum and postpartum of sepsis. And as you heard in Maylee's story, that was a postpartum sepsis case. She had lots of signs and symptoms of being toxic and quite ill. So the adult sepsis tool should be used in the postpartum period, but you have to have the suspicion. The think sepsis criteria. Then antepartum, it's really, you need to use the pregnancy adjusted criteria. And our data, we looked at several different time points antepartum, and 20 weeks appears to be a good marker, which is when most people would present to L&D in any case.
Hi everyone. Hi, Dr. Mean. I'm sorry to interrupt. We're at time for questions, but we will do our best to answer any of the remaining questions after the remainder of the presentation. So thank you all very much.